Then there's a few other things we're quickly going to go through and then we're done. Permanent methods I'm not going to spend any time on. Vasectomy is one of our ones with the lowest failure rate, a 0.1% failure rate. There is some issues in terms of regret with vasectomy, so you need to have very good counseling. It's one of the few methods where the man has control over his fertility, so it is an important part of your discussion, especially with men who want to be able to have some say in terms of what is happening with their fertility. But the bilateral tubal ligation, it's becoming more and more controversial why we are actually doing that. It's a good option in your woman who's had like 5 kids and now she's just had a baby and she doesn't want to have more children, and you quickly do a ligation, and in theater, for example. But actually for a lot of women, considering something like your IUCDs, for example, or your is actually a much, much safer option, and has got less complications, for example, with surgical complications. Just a quick word on emergency contraception. Again, not us to judge and decide when we should or shouldn't give it. If somebody needs emergency contraception, they should be able to get that. Very important in sexual assault with our children, even if they don't yet have periods, if they are a breast stanner stage 3, they also need to be getting emergency contraception because you can't predict when the first ovulation might happen. So just to be on the very, very safe side. So we all know this. You give your it's either your levonorgestrel at 1.5 milligrams ASAP. And if they do vomit in 2 hours, then you do need to repeat that dosing. Or you can use your copper IUCD also within that first 5 days, especially if they're going to need long-term contraception anyway. So just a reminder, I'm sure you're all aware of this, in women who weigh more than 80 kilograms, or if they're on enzyme-inducing drugs such as fluconazole, rifampicin, carbamazepine, phenytoin, then actually the copper IUCD might just be a better option. But there is a recommendation of doubling the dose of levonorgestrel in those patients. If there are no levonorgestrel in your clinic and all you have is the pill, you can use your normal Nordet 6 tablet stat and then 6 tablets in 6 hours. So that is another option. Remember to do your HIV counseling and your post-exposure prophylaxis as well. And then you need to advise the patient if this period is going to be more than 7 days delayed to obviously have a pregnancy test. But sometimes you're putting patients on an injectable or a POP, so they're not going to have a period again. And then you actually want to do a routine pregnancy test 2 weeks after you've seen them. Just a couple of, oh no, I don't have special, because I filled the special populations in earlier. Thank you very much, everybody.
This is one topic we want to look at
In some time, yeah.
And this is one of the common reasons